audit because this is, of course, still a new technique in many institutions, so it's better to be audited and recorded for updates and applying of the new updates for it. So what's lung recruitment? Actually, when we say lung recruitment, it means opening up collapsed alveoli to improve oxygenation. So lung recruitment it means if we have collapsed lung or attenuated lung for any reason, we need to open up these alveoli to do alveolar expansion, of course, which is controlled to improve oxygenation. So there are many maneuvers to do lung recruitment by increasing airway pressure to open up the collapsed alveoli and enhance alveolar units involving entitled ventilation to improve the oxygenation. So let's see this video. This video will show us. Do you hear me? Everybody is listening?
Yes, yes.
So and the picture, video, everything is clear for the other colleagues? Okay.
Yes.
Okay. Let's see this lung. This is a big lung, and let's see at 0 beat, you will find this lung like collapsed totally. So now we are at 5 plus 5 cmH2O beat. So the lungs start to be inflated. So when we increase the beat to 10, the lung is more and more inflated. And he will increase up to 20 beat. You can see now how much is the lung inflated. It's significantly inflated than before. This is what we call lung recruitment. Lung recruitment, it means inflation of this lung to do its function. Its regular function, normal function of oxygenation. Anybody want to repeat the video again, or is it clear?
Again, please. No,
Huh?
again.
Again.
Yes, please.
So again, we'll repeat the video. Now, if you notice, the beat here is 0. So the lung almost collapsed. When we increase beat to 5, this is BIB. Okay? We are not talking about BIB, which is the peak inspiratory pressure. We will talk about beat, which will make sustained lung recruitment. So now we'll increase beat to 5. Now you can find the lung is recruited, inflated more than before. And when beat increased more to 10, you'll find it more recruited and more inflated. And when increased to 20, you'll find it more inflated. So this is what we mean by lung recruitment. Lung recruitment, simply lung inflation, alveolar dilatation to do better oxygenation. Okay?
Yes.
Okay, so what are the strategies for successful lung recruitment? If we want to make lung recruitment for any neonate who have respiratory distress. So for even from the start, from BBV in delivery room, resuscitation using TBs, of course, TBs nowadays is preferred due to better effect and less complications, less pulmonary dysplasia. It's preferred than Ambovac. So if you do BBV by Ambovac or TBs at delivery room because the baby has respiratory distress, this is some strategy of lung recruitment because this will affect the lung by increase the tidal volume and open up the alveoli as we mentioned before. Also, when we shift the baby to the unit and start neonatal ventilation, either conventional or high frequency, invasive or non-invasive, this will achieve lung recruitment. Surfactant administration, which is very important in management of respiratory distress syndrome, this will help us to achieve lung recruitment. And this is very clear. Once we give surfactant administration, we will start shortly after giving surfactant administration to decrease the levels of the pressure and FiO2 significantly. So the lung function will improve by surfactant in spite of we will decrease the pressure, BID and FiO2 and the other parameters gradually after surfactant administration. This means that this lung has improving recruitment and improving function after surfactant administration. Even without using direct strategies to the lung itself, a general condition affecting the lung and causing some sort of inflammation, stiffness, collapse, consolidation, like septicemia or pneumonia. When you treat sepsis, lung recruitment will improve if you have pneumonia, for example, or cardiac problem like pulmonary stenosis or resistant pulmonary hypertension. When you improve it, also when you treat it, the lung recruitment will improve as well. So let's shift to surfactant administration, which is the main cornerstone of our lecture today. So administration of exogenous surfactant to a newborn infant who is at risk of respiratory distress syndrome is already established practice which improve lung recruitment. Infants with RDS who are treated with early surfactant and CPAP are less likely to need mechanical ventilation and suffer from air leak or develop BPD than other infants treated with CPAP and later surfactant therapy. So in early trials, the delivery of surfactant was by endotracheal intubation. So early, we were giving surfactant to ventilated babies by ET tubes. I will show you here in this picture a way of closed circuit surfactant administration. This is a very nice way if you have a baby who is ventilated. So in these babies, we can connect the tube with this Y-shaped top of the tube to connect the ventilation in one limb and to connect this circuit in the other limb. This is closed circuit surfactant administration. This is the surfactant. And we can introduce this minimal tube inside into the endotracheal tube and give the surfactant while the patient is still connected to the ventilation and keeping the lung recruitment by the pressure giving to the patient through the ventilator. So with this way, there is no need to disconnect the ventilator from the baby and give surfactant and then reconnect, because this may lead to lung collapse. That's why this way is better to give surfactant with the closed circuit for ventilated babies. We have many alternative ways to give surfactant for surfactant administration nowadays. There are several ways. There is MEST technique, which is minimally invasive surfactant therapy, allows spontaneous breathing unit to remain on CPAP in the first week after birth. MEST has included administration of exogenous surfactant by intrapharyngeal instillation or nebulization or laryngeal mask and thin catheter. So we have LISA technique. LISA technique is less invasive surfactant administration. We will use Serfocat, and we will show you in the next slides. And we can give surfactant directly by it for babies who is able to breathe normally and taking spontaneous breathing on CPAP without disconnection of CPAP. We can give them surfactant and we will achieve lung recruitment and stability of vital signs quickly and improvement of the lung condition and respiratory distress. In short, which is the previous fashion in the previous 2 decades, intubation, surfactant administration, and extubation. SALSA technique for giving surfactant, which is surfactant administration using laryngeal or supraglottic airway. So this is a Serfocat. This is the catheter which we can use to give the surfactant by LISA technique, and it's very easy and simple to give, as we will see in the videos. So the babies who are on nasal CPAP, who are breathing spontaneously but have respiratory distress syndrome, severely distressed, either extreme preterm or premature, and they need surfactant, we can give them by LISA technique by this Serfocat. This is a laryngeal mask which we can use also to give surfactant by applying this laryngeal mask on the larynx and give surfactant through it. And this will be counted as this amazing maneuver for giving surfactant administration as well. But by the way, self-pass is more common than laryngeal mask to be used for surfactant administration as an example. These are common types of surfactant we are using in our unit, which is Kerosene, which is pork-based surfactant, and Servanta, which is common. Actually, both are almost the same effect. I'm using both, even in some twins, I'm using both, one for this and one for that. So both are effective, but we have some advantages on with kerosene. The first advantage is amount. So the volume of kerosene needed is much less than the volume of Servanta needed because of the concentration. So for 10 babies, we can use only 3 ml for the babies who need surfactant of kerosene. In spite of for those babies, we'll use at least 8 ml from Servanta, which is too much. Also for the second dose or the successive dose, if needed, we can use 1.5 ml of kerosene. And I can say there is a little bit better effect with kerosene than Servanta, but both are doing the same effect at the end. So early use of thin catheter surfactant administrations appears to be safe and reduce the need for mechanical ventilation in many preterm infants, while it doesn't increase the risk of IVH, pneumothorax, or BPD. And this is a very important point. When we give surfactant by LISA, it doesn't increase the risk of IVH and pneumothorax or BPD. In spite of that, it decreases the risk of pneumothorax and decreases the risk of BPD because you can give surfactant very early and you don't wait a long time until ventilation, stabilize the patients and get the surfactant and give it to the baby. You can give it even in OR or LDR if the baby is eligible for Servanta. So attending deliveries for the babies who are extreme preterm babies, 24, 25 weeks, we expect they will need Servanta soon after delivery, and we can give it in LDR directly by the catheter. And put the baby in nasal CPAP or nasal CPAP and get it from LDR to in ICU, so we'll keep the lung ventilated and recruited all through the circuits without any chance for collapse. Performing LISA indications and timing. Infants who are suitable to be considered for LISA are those being managed with primary CPAP or high flow nasal cannula with evidence of increasing respiratory distress. So the babies who will get LISA technique should be breathing spontaneously. They have respiratory distress, yes, but they are breathing spontaneously, they are not apneic, and there is no indications for ventilation. If there is no indication for ventilation, of course, you will give Servanta through the attitude. As we mentioned before, with the closed circuit will be much better than open circuit. So recent evidence suggests that the threshold for FiO2 of 30% should be used for all infants less than 32 weeks of gestation to reduce complication in untreated RDS. So if the baby is on nasal CPAP, having respiratory distress syndrome and needs FiO2 30% or more, with findings in the X-ray, this baby will be eligible to give surfactant by LISA technique. Infants less than 32 weeks gestation can be assumed that their oxygen requirements is most likely surfactant deficiency and should be given surfactant via LISA without waiting for a chest X-ray to confirm the diagnosis. I have commented on that. We have to wait for chest X-ray. I got this point from the textbook, from the research which I got. To make only a comment on that, we have to wait for the chest X-ray. Why we have to wait for chest X-ray? Because you could find the abnormal findings, even with respiratory distress syndrome. Sometimes this respiratory distress syndrome could be associated with congenital pneumonia as well, with a friable lung. So you have to recognize the case well and know for who you will give surfactant. If this lung is friable, if the baby with severe congenital pneumonia, once you give surfactant, most probably the lung will be ruptured and you will have airlick syndrome which is easy to be pneumothorax, but it could be much more dangerous, like pneumodistina or interstitial air leak syndrome, which will be dangerous. So you need to wait for chest X-ray. Chest X-ray, we have portable chest X-ray, which will be done within few minutes. We'll call them and they will come to do. And we can give surfactant upon the chest X-ray plus the requirement for FiO2 as per the latest guidelines. If RLS is diagnosed, surfactant should be given promptly. يعني كل ما تدي السرفاكتنت اسرع كل ما يكون الافكت افضل if you have a clear diagnosis for RLS. In units where there is this technique is still relatively new, it's advisable that it's performed under the controlled environment within the natal intensive care. As teams become more confident, there may be scope of using techniques in the delivery room. So, perform LISA in infants less than 32 weeks gestation with any persistent or rising FiO2 requirements following stabilization on non-invasive respiratory support. The aim is to treat with surfactant before FiO2 requirements reach 30% at any time in the first 72 hours, or as soon as possible if FiO2 is already 30% or more following stabilization of the baby. Performing LISA in infants more than or equal to 32 weeks of gestation with persistent or rising FiO2 requirements more than 30% following stabilization on non-invasive respiratory support if X-ray confirms the diagnosis of surfactant deficiency by ground glass or by white lung, whatever the signs in the X-ray of RDS. Treatment may be considered at any time in the first 72 hours. As early as you can will be much better. At consultant discretion, LISA may be performed without awaiting radiological diagnosis in an infant with higher initial oxygen requirements, FiO2 more than 40%. But again, X-ray is better to be done if you have the facility. If you have portable X-ray, better to do the X-ray and take a look for the lung before you give surfactant. Consider pneumothorax if any infant who experiences a rapid rise in FiO2. In any baby, even if, especially if we give surfactant administration, and the baby needs more FiO2 or decreased saturation, sudden decrease in saturation, please consider pneumothorax as we all know. In this X-ray, as we see, this is the AT tube, and this is the orgastric tube. The whole mediastinum shifted to the left by right side of the pneumothorax around the lung, even the right side. Right lung is compressed by the pneumothorax, and there is tube in the second right intercostal space. There is ICD, intercostal drainage tube, for this tube. Contraindications to performing LISA technique. Absolute contraindications, imminent need for intubation. If the baby is in need for intubation due to apnea or respiratory failure or failure of non-invasive ventilation. So if you are intubating the baby, better to do through the tube, not by LISA. Or if you have maxillofacial or tracheal or non-pulmonary malformations, alternative cause of respiratory distress, congenital pneumonia. Also, it might be a contraindication. Why? Congenital pneumonia, as we said, the lung, if we have infection, if we have severe infection in the lung tissue will be friable, and by giving LISA, this could affect the lung tissue and could lead to air leak syndrome. Here, it's a big debate and controversy actually in reality. When we have a baby with respiratory distress, preterm baby with suspected congenital pneumonia and respiratory distress syndrome at the same time, which can be come together. So this will be a debatable to give or to wait for surfactant administration. So non-experienced personnel available to perform surfactant, to perform LISA is contraindication actually to give LISA. No need to give if there is no experienced personnel who have a very high skills in intubation to perform LISA. Relative contraindications, severe respiratory distress syndrome with high oxygen requirements, severe respiratory acidosis, widespread atelectasis on chest X-ray, suggested threshold for intubation being preferable over LISA If FIO2 requirement is more than 50% in less than 32 weeks or more than 60% in more than 32 weeks babies of gestation, so this will be relative contraindication for laser to give by 82. Consultant discretion, if consultant decide not to give by laser and give by 82, if the condition of the baby is preferred to be dealt with 82. Infant less than 26 weeks of gestation in the unit just starting to use laser. So if there is no experienced person to do laser. Pneumothorax requiring drainage also is a relative contraindication. You can give, you cannot give. It depends on your assessment. So you can wait, you can treat the other lung tissue and taking the decision to give surfactant or not, depending on the lung tissue and the general condition of the baby. Prominent apnea despite adequate caffeine centrate. So this is an indication for intubation. So why you give by laser if you have indication by intubation for intubation? So intubate the baby, give surfactant through the tube, 82, while the baby on mechanical ventilation. Preparation and pre-laser preparation, equipments and pre-laser preparation. So it's preparation for laser is very similar to that for elective intubation. The infant should be positioned as it for intubation and swaddled for comfort. It's important that the baby has continuous monitoring of heart rate and oxygen saturation. Of course, when we give surfactant by laser, the baby will be in continuous monitoring. They should have an orogastric tube in situ, and stomach should be aspirated during this maneuver to avoid injection of surfactant to the stomach. The baby should have intravenous access. Of course, all the babies will have cannula or UVC or central lines at this time, and confirm it to be working if you need to give medication at this time or sedation. Usually, we'll give sedation by sucrose only, sucrose drops in the nurse. It is important to maintain the baby's temperature. Of course, we will open the incubator during this maneuver, so it's important to keep the baby's temperature throughout the procedure. And as much as the personnel is experienced, they will do it fast, so this will be much better for the baby to keep the body temperature. Ensure that the infant has been commenced on appropriate dose of caffeine citrate and those given at least 30 minutes prior to the procedure. This will help the baby's breathing spontaneously. A new buff or self-inflating bag at appropriate sized mask should be available as appropriately sized endotracheal tube should be at the procedure if there is any hypoxia or persistent hypoxia or bradycardia or apnea happens. So this baby might need intubation. It never happens with me. I gave surfactant by laser for dozens of patients, more than 20, 30 patients last year, maybe, and there is no one of the babies, either extreme low birth weight babies, extreme premature babies, or premature babies more than 30 weeks need to be intubated at this time. Surfactant should be drawn into a 5 ml syringe to be delivered through the course via laser catheter. Of course, if it is surfactant itself, so if you need more than 5 ml, you will use more than 5 ml syringe. So you can use the 10 ml syringe. Radiolaryngoscope can be used to insert the laser catheter. If it is available in your institute or in your hospital, you can guide it, the intubation and giving surfactant by laser through the radiolaryngoscope. CPAP or high flow should be maintained throughout the procedure. So the baby will be connected to nasal CPAP by nasal mask or nasal plunge and will hold the baby and put him in the intubation position and will insert the tube, the laser tube, and will give surfactant through the laser catheter. And after that, we'll remove the laser catheter while the baby also does the procedure is still on the non-invasive ventilation, which is most probably CPAP, sometimes high frequency ventilation. So this is what we have to do during surfactant and prior to surfactant administration by laser technique. Infants should be given caffeine citrate, of course, to help his breathing, continuous heart monitoring and saturation monitoring, OGT with stomach aspiration or aid surgery, IV access, maintain temperature of the baby, neobuff and self-limiting bag and mask, ET tube, fixator and pedicap to keep the baby's temperature, and the Lisa catheter, surfactant, whatever the dose you will give, and video laryngoscope or standard laryngoscope with appropriate sized blade, and be sure that it's fine. This is a video laryngoscope you will introduce inside the larynx, and you can see the view as it is in the picture. And through this, you will put your catheter and you will give surfactant by catheters with help of video laryngoscope. It's a very nice tool, and it makes it very easy to intubate even for non-experienced personnel. This is a surfactant again. It's very important. This is a key tool to give surfactant by laser technique. These are CO2 detectors. There are many people who use, in some institutes, not all, who use this CO2 detector to confirm the position of servocas inside the trachea. So after you insert the servocas inside the trachea in the larynx, you can connect with the CO2 detector through the tab of the attitude 3. And if this color, the violet color, change to yellow color, it means it's inside. And you can, at this time, you can remove the CO2 detector and give surfactant because you confirm the position. In other institutes, they are not using this and they are giving surfactant directly because actually you can see the view of the larynx and it's very clear to insert the catheter, the cervicus through the larynx, and you'll be sure that it's inside. To confirm by CO2 detector or not, it depends on the institute and the guidelines, which can be changed from place to another. These are the AT tubes. Of course, we can take this tab, which is the AT tube 3. You can take this tab and connect with the cervicus, connect with the CO2 detector if needed. Sedation, we can use sedation for the babies who are going to be given LISA, but no RCTs have looked at the use of pre-medications for LISA, but expert opinion suggests that pre-medications may be considered. It is not that laryngoscope was adverse physiological response, including systemic, pulmonary, and intracranial hypertension and bradycardia. But with the use of pre-med, these effects as well as pain and discomfort can be reduced. Some practice are to give awake sedation with naloxone available. So if needed, they will give naloxone. And some will give atropine if there is bradycardia. All of these practice, it depends on the institutional guidelines, which it's different from institute to another, different from hospital to another. So for some infants with non-pharmacological methods, maybe all that is required to perform LISA. In the less mature infants, the use of sucrose and swallowing seems to be tolerated very well and reduce the risk of apnea associated with fentanyl administration. So as I told you, mostly we are using sucrose administration, and we never give sedation or fentanyl or midazolam before LISA. So these are the medications which can be given: sucrose or fentanyl. Surfactant, of course, we will give. Atropine, if needed, we can use it if there is significant bradycardia and persistent bradycardia, and top up dose of fentanyl if needed. Less invasive surfactant administration LISA, this is a neonatal guidelines. It should be performed or supervised by staff members who have been trained in how to carry out the procedure and who are competent at intubation. The video laryngoscope where the operator is comfortable with it, so it can be used and may be used for LISA procedure to assist for accurate positioning and for LISA sterilization. I know the time is almost finishing. I would like to show you this video, and this is a video of preparation for visa administration. Do you hear the voice?
Yes.
It's okay. It's okay. So this is a video for preparation. This is a Kenusef, of course, you love syringes, and this is the Serfo cat. I don't know if you can hear the voice in the video. So maybe who's stressed and interrupting. Here is the team. This is from our unit as we are preparing the baby for surfactant. The baby is connected already to the nasal CPAP, and we will position the baby and give surfactant by laser technique while the baby is connected to the CPAP. Suctioning is here, and it's ready to be used if needed, if there is secretions which will obscure the view of the larynx and can be used. So this is the suction catheter to be repeated. So there is some secretions obscure the view, so we'll do some suction catheters. Some suction. I can show you the view with insertion, but it's not easy for the photographer to. Now I inserted the tube inside the larynx. Okay. Well, the tube is already inside. I will fix the tube, and we'll take the surfactant while we are monitoring the baby. Some babies will have tachycardia, some will have some bradycardia, some temporary desaturations, but it will be managed. This is another video. This was given for a 28 weekers with RDS. This was twin 2. Twin 1 was fine initially, but he needs surfactant later before passing of 24 hours. Chest X-ray and the final requirements was okay, but by time he needs more. So chest X-ray deteriorates a little bit, so we give surfactant for twin 1. Twin 2, give it surfactant soon after delivery by one of my colleagues, Dr. Zakaria. So I just like to give. It's done under my supervision.
لا معلش انا بعتلك حاجه. لا وبرضه ايه ضايقيهم لغايه لما يقولوا.
So there is our ambo bag as a rescue. The baby is in CPAP. He has severe respiratory distress.
وانت ابعتي كل الجروبس اللي عندك. اوكي خلاص الله يخليك. واي مجموعات ثانيه هبعتلك حاجه.
الصوت بعد إذنك يا دكتور سامح.
This is a check of laryngoscope blade if it is working properly or not. You have to be sure that the light is proper, not faint. This is the catheter. I wish I can show you the view over here. Can you see the view? Do you hear me?
Yes, we hear you.
So
Yes,
I want to confirm if they can see the view, our colleagues who are watching us.
No, Dr. Muhammad, the view is not clear, but we can hear you.
Well, I'm trying, I'm trying, but it's very hard to get it. This is the best way because we take it during our insertion already. So I think it's yes, and then surfactant given to the baby after that. Is the process clear now?
Yes, دكتور محمد it's clear. هو ما فيش تشينج في البوزيشن صح؟ اللي احنا شايفينه في الصورة.
مفيش change؟
change في البوزيشن of the
لا احنا بس لفينا البيبي لو حضرتك لاحظتي احنا لفينا البيبي البوزيشن بتاعه
ولا خد ولا رايت ولا ليفت، هو the same position.
لا it's the same position. خلاص it's يعني this was an old practice to change the position 4 times to give 4 aliquots before. This is an old practice. Nowadays we are giving only one shot. It's the same position and gives the
يعني
Sorry, I couldn't hear you well. There is interruption in the voice.
The same position ده اللي اقصد ان هو supine ما خدناش اي وضع يمين او شمال.
لا خلاص ما عادش بيحصل الكلام ده خلاص. It's obsolete long time. even في على الايتي تيوب لو البيبي انتيوبيتد وهندي برضه ما عندناش بنغير البوزيشن زي زمان. كمان بنعمل بالكلوز سيركت عشان يفضل محتفظ باللانج ريكروتمنت الى حد ما يعني سواء بالايتي تيوب او الليزر.
بندي بريشر بعد كده سيباب او
لا خلاص. شوف حضرتك احنا بندي دلوقتي ما بنحتاجش ندي اي بريشر زياده زي زمان كنا بندي فعلا وبنعمل الفور بعد فوق افري اليكويت ندي امو باك 15 to 20 seconds. ده ما عادش بيحصل دلوقتي. احنا بندي حضرتك دلوقتي الكاسيتر موجوده هي بندي السرفاكتنت والسيباب كونكتد تو ذا بيبي، فهو اصلا السيباب فلو بيعمل ديسبرشن وديستريبيوشن للسرفاكتنت باي اتسيلف. مش محتاجه انت هتدي السرفاكتنت وتشيل التيوب وشكرا وخلاص والسيباب مكمل. واضحه؟ الو
Dr. Mohammed, I think there's something wrong with the internet in Dr. Arda.
I think so. But we'll wait for her. When she come back, we'll continue our discussion. So I will continue until she come back and we can answer her question. So post-Lisa, after administration of surfactant, the baby should be nursed through on nasal CPAP or BiPAP, whatever the mode you use. If the procedure has been successfully, there should be a marked reduction in oxygen requirement within hours of the procedure. So if you have FI to 35 or 40%, most probably within a few hours, it will go down to less than 30%. And this is a sign of improvement, of course, for lung recruitment, of course. If the baby develop an increasing oxygen requirement, consider a pneumothorax as we mentioned before. Further dose of surfactant should be considered. This could be administered by Lisa if they don't meet any other contraindications. However, if they have marked work of breathing or persistent high oxygen requirement or respiratory acidosis or severe RDS, so intubation should be considered. دكتورة رغدة
انا عفوا
انا بخلص انت بس عشان الانترنت.
بالظبط. بعد ما حضرتك تخلص انا محضره الاسئله. انا اسفه طبعا النت بتاعي قطع ورجعت تاني، فبعد ما حضرتك تخلص. اوكي شكرا لحضرتك. اتفضل دكتور محمد.
تقريبا يعني في اجازه. سو احنا هنعمل اوديت طبعا لكل الحالات، يعني اي حاله بنعملها في اليونت بنعمل لها اوديت لده نيو بروسيدور. فاحنا بنعمل اوديت يعني بنعمل بريفنج ودي بريفنج. قبل ما بنجهز بنقول احنا هنعمل ايه، وبنجهز ونعمل بريباريشن ايه وايه اللي هنعمله ده للتيم كله. وبعد ما بنخلص بنعمل دي بريفنج ومصورين وبنشوف فين الديفكتس، هل احنا عملنا هنا حاجه مش مظبوطه، هل عملنا هنا مشينا هنا كويس to يعني treat the weaknesses and improve the strong areas. So auditing is very important. These are some studies done on LISA procedure in many companies, so many countries. So I got many of them just for you if somebody want to check and take a look for all of these studies. And these studies prove that LISA technique is very effective and decrease the risk of BPD and IVH in newborn infants, especially premature. This is another study, and this is a study from the US. US came late for LISA, by the way. I mean, in Europe, China, and Asia, they used LISA much more before US. This is another one. So a lot of studies in Europe, Germany, and the US later on. So take home message, surfactant administration is one of the most important strategies to establish lung recruitment in neonates. The administration of exogenous surfactant to newborn infant with risk of respiratory distress syndrome established practice. Infants with RBS who are treated with early surfactant and CPAP are less likely to need mechanical ventilation. Thank you.
Thank you a lot. Thanks a lot دكتور محمد، محاضرة كالعادة رائعة، واحنا فعلا استفدنا من حضرتك قبل كده في محاضرة مماثلة، وعندنا أسئلة كتير هتصدهم تماما وحاجات صغيرة جدا. كنت عايزة أسأل حضرتك أول سؤال على نوع، حضرتك ذكرت الكيوراساب بالاسم وقلت إن احنا كل ما الأماونت صغر كل ما كان الطريقة أحسن. بالظبط في الاماونت. فميبي احنا عندنا احنا في مصر بنستعمل الالفيوفاكت، معرفش حضرتك عندك اكسبيرينس بيه ولا لا. هو تركيز 54 و108، وايفن كان هيئه الدواء بعتت لنا some instructions وان احنا نشوف البيبي قبل وبعد. فلو عند حضرتك اكسبيرينس في الالفيوفاكت بالاسم we would like to know it. ده السؤال.
للاسف انا ما استخدمتوش خالص لانه مش موجود هنا، مش متاح هنا، وما اعرفش الايفكت عنه، يعني الايفكت بتاعه هيبقى ازاي لو استخدمناه. بس هو يفرق معايا الفوليوم قبل ما استخدمه. هو في تركيزين 54 و108. الفوليوم بتستخدمها قد ايه بير كي جي؟ في ال 108 مثلا بتدي قد ايه؟ 2 مللي بير كي جي ولا؟
بوصل ل 2 سم، فدي كميه
3 هتديله 6 مللي، فالفوليوم بتاع ال 108 هيكون افضل كفوليوم من ال 54. ال 54 هتدي منه 4 مللي بير كي جي، فممكن يستخدم الاكستريم بريتيرم بيبيز اكتر. بس كل ما تقلل الفوليوم كل ما هيكون افضل بالنسبه للافكت بشكل عام، علشان كل ما بتقل بالجستيشنال ايج كل ما بيصغر الدايمتر بتاع الاي تي تيوب. كل ما يصغر الدايمتر بتاع الاي تي تيوب مع السيرفاكتنت بيبقى الابزوربشن التوليرابيلتي بتاعت اللنج بتختلف من بيبي للتاني، ان هو يتوليريت السيرفاكتنت. في بعض البيبيهات بتحقني ويحصل ما يحصلش ابزوربشن كويس للسيرفاكتنت في اللنج، وتضطر ان هو يقفل التيوب لان هو في كل الاحوال بيبقى ريستس، وبتضطر تعمل تشفيط لجزء من السيرفاكتنت اللي انت حقنته، فما بتبقاش افكتيف دوز. فكل ما يبقى الفوليوم قليل كل ما هيكون افضل بشكل عام. انما كافيكاسي لا، ما جربتوش للاسف.
تمام.
يعني
طب
لو جربت
لا.
ان شاء الله
ان شاء الله يا ريت. طب يعني لو حضرتك how to monitor الكيوراساب، يعني لو حضرتك قلت ان انا بعمل auditing، هل في points محدده عشان evaluate نوع السيرفاكتنت؟ يعني وانا بعمل الاوديتنج يعني دي هتبقى مهمه جدا لكل الاوجنت اللي بيستعملوه، لان ده جايه لينا كلنا، هتبقى مهمه جدا. يا ريت حضرتك تفيدنا فيها.
طبعا. طيب هو عموما انا لما استخدمتهم النوعين في نفس الحالات، استخدمتهم على توائم بنفس الحاله، بنفس ظروف الحاله تقريبا، بنفس البارامترز، واستخدمت الكورسات واستخدمت السيرفاكتنت. يعني بقيت ادي مثلا توين 1 سيرفاكتنت وتوين 2 كيروسيف. بقيت اشوف الريكوايرمنت اوف اكسجين قلت بعد قد ايه في كل توين. السيفيريتي اوف ريسبيراتوري ديستريس قل بعد قد ايه من الوقت لكل واحد. ال ال to reach 21% FiO2 لكل بيبي من البيبيهات، اخذ وقت قد ايه معايا؟ هل اخذ ممكن في الكيروسير بيوصل بسرعه، يعني انت يعني اللي لاحظته في الكيروسير في معظم الاطفال لو اديتي الكيروسير في خلال من ساعتين ل4 ساعات بيحصل دراماتيك ريسبونس للسيرفاكتنت، وبيقل الاف اي 2 سيجنفيكانتلي وبتنزلي تحت ال 30% بسهوله، واحيانا بتوصلي ل 21% في معظم الحالات بسهوله. بيقل الريسبيرتوري ستريس السيفيريتي والريتراكشنز بتقل كتير جدا، والجراندنج بيقل وبيبقى اولموست ديسابيرز، ويبقى موستلي بس البيبي تاكيبنك وعلى سباب ومحتاجش اي مشكله. تمام؟ السيرفاكتنت نفسه بياخد وقت اطول شويه، بيزيد اب تو 6 اورز. دي الحاجات اللي احنا لاحظناها وعلى دوائر، يعني في معظم الحالات ما اديتش الحالات مختلفه عشان ما يختلفش الانبوت من حاله لحاله. بياخد تقريبا 6 ساعات. بيبقى الامبروفمنت الاف اي 2 اقل من الكيلوسير، يعني لو انا بدات اقلل الاف اي 2 بعد ساعه مثلا الكيلوسير، ببدا اقلل بعد ساعتين. طبعا بنقلل فيري جراديوال بعد ساعتين من السيرفنتا او بعد 3 ساعات. وطبعا ويز تارجت اوكسجين، يعني احنا عندنا تارجت اوكسجين فروم 88 تو 93%، ونبدا نقلل طالما البيبي هاز ستابلايزد اوكسجين ساتوريشن نبدا نقلل الاف اي 2 بالتدريج. برضه الامبروفمنت اوف ستريس ساينز كلينيكال ساينز مع الكيلوسيرف احسن من السيرفنتا كتير، ده برضه لاحظناه. ان انت تو ريتش 21% اللي هو الروم اير على السباب اسرع مع الكيلوسيرف واقل مع السيرفنتا.
تمام، هايل. يعني ريفيو رائع، ربنا يكرمك. في سؤال تاني بقى كان معلش، هو طبعا الموضوع مهم جدا بالنسبة لنا علشان يعني محتاجينه. آخر حاجة اللانج الترا ساوند، يعني حضرتك قلت اللي أقل من 32 أنا هديهم من غير ما استنى إكس راي ولا هعمل حاجة وهدي على طول. حاليا يعني حضاناتنا دلوقتي فيها
الليتريتشر اللي انا كتبتها قايله كده، بس انا معترض عليه. انا عندي اكسسبيليتي اوف
تمام.
سهل ان انا اعمل اكس راي.
اه اه يبقى عشان كده حضرتك اكيد احنا يعني ساعات بنستعمل اللانج الترا ساوند كجايد، صح كده؟
انا معاك جدا طبعا.
تمام. دكتور محمد حضرتك سامعني؟ تمام، اوكي. احنا بنشكر حضرتك جدا، وطبعا عندنا اسئله كتير بس عشان الوقت، فبنشكر حضرتك جدا على المحاضره الرائعه الاكثر من رائعه المفيده جدا. ان انا ريبيت، يعني
ما عندناش اي مشكله، بالعكس اتس سايد تول ودي بوكس وحاجه رائعه لو موجود لانج الترا ساوند. الترا ساوند ماشين والاكسسبيلتي موجوده نقدر نعمله وتوليد اصل وجيب سيرفاكتنت. هي قصه بس اللي انا عايز اقولها لك في نقطه ليه انا مصر على الاكس راي في يعني يعني if it is available، يعني هيبقى افضل ان انا اعمل اكس راي. لان انا هديك مثال بحاله مثلا جت معانا، كان بيبي بريماتيور، كان 31 ويكس وديليفرد وذ سيفير ريسبيراتوري ديستريس كلير انديكيشن فور سيرفاكتنت ادمنستريشن. البيبي ده اتعمل له اكس راي، والاكس راي بتاعته كانت مبينه البيكتشر اوف جراوند جلاس ابييرنس، كان فيها سام سورت اوف هيزنس برضه، يعني تمشي كمان كونجنتال نمونيا. ولما عملنا ديجنج ورا الهيستوري بتاع الام لقينا ان كان في امبريدنج رابشر يوترس وهم بيعملوا السي اس، لان هي جت في ايرلي بريتيرم ليبر ودخلوها سي اس، وكان في امبريدنج رابشر لان كان عندها بريديوس سي اس قبل كده، وكانت الام دي عندها ريسك اوف انفكشن والبيبي كان انفكتد. البيبي ده ادينا له السيرفانتا وتحسن اموره مش بس، وبعدين رجع ديتيريوريتد تاني. بعد ما بقى ديتيريوريتد احنا عملنا اب تو تشيست سي تي واكتشفنا ان البيبي ده فيه سيكا سيستيك ادينوماتويد مال كونجينيتال سيستيك ادينوماتويد مال فورميشن. فانت بتحاولي ان انت لما بتعملي الاكس راي او اللانج الترا ساوند تو كلاريفاي ذا كونديشن اوف ذا لانج. انا هدي السيرفاكتنت او السيرفانتا بتاعتي على اي كونديشن وهبقى متوقع ايه. فلو تخيلت ان اللانج مثلا فيها ريسك اوف كونجنتال انفيزيما او سي كام، اكيد لما هدي السرفاكتنت ممكن يبقى عندي في some sort of complications totally different than the respiratory distress syndrome. عشان كده بيبقى الاكس راي مهمه قبل ما ندي السرفاكتنت.
تمام، ألف شكر لحضرتك، ميرسي جدا دكتور محمد.
شكرا يا فندم.
محاضرة أكثر من رائعة.
ألف شكر يا دكتور محمد، استمتعنا بالمحاضرة جدا 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 جدا. ألف شكر.
شكرا يا فندم.
تسلم يا فندم.
شكرا حضرتك يا دكتور سامي.
ألف شكر يا فندم، ربنا يكرمك. Thank you very much.
سلام.
Excellent. أحمد. Mr. Dr. Hussein Safar, he's an eminent consultant, pediatric endocrinology and diabetology in Sultan Qaboos University in Oman. Are you hearing me?
I'm with you.
Okay. His presentation today will be about congenital hyperinsulinism of infancy, pathophysiology, and management. The floor is yours, Dr. Hussein, and we will ask you after you finish your presentation. Thank you very much indeed.
So, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum jami'an wa rahmatullahi wa barakatuh. Thank you very much, Prof, for your kind invitation. And it's a pleasure for me to be with you guys in this amazing conference so far. So, within the next 30 minutes, I will shed a light on congenital hyperinsulinism. Here are my disclosures. And I will cover some pathophysiology of hyperinsulinism. Then how could we reach a differential diagnosis for congenital hyperinsulinism, and how can we manage this case? So congenital hyperinsulinism is the commonest cause of recurrent and persistent hypoglycemia in infants and children. And it can be presenting with different kind of features and symptoms. So neonatal hypoglycemia, then it becomes persistent or recurrent, that would be one of the features of how it presents. Sometimes it presents for first time with seizures, and then with the workup of that seizure, you discover that this patient is having hypoglycemia. Sometimes developmental delay due to recurrent, untreated, unrecognized hypoglycemia, lethargy, of course, tiredness, unresponsiveness, and coma, and then that with workup will find hypoglycemia. So the presentation of congenital hyperinsulinism basically depends on the hypoglycemia, how it manifests itself. Causes of hyperinsulinism, we can divide it into 3 categories. And perinatal factors, for example, as causing factors for hyperinsulinism, that could be related to stress-induced hyperinsulinism in cases of small for gestational age, IUGR, prematurity, extraordinary resuscitation, maternal preeclampsia, sometimes even with the insertion of arterial lines. Hyperinsulinism can be also associated with a number of syndromes like Beckwith-Wiedemann syndrome, Kabuki syndrome, and Turner syndrome, or could be more related to a gene defect, and this is what we call it monogenic defect, cause of hyperinsulinism. So the monogenic defect, so far plus 12 genes being recognized. The most commonly recognized gene and most common cause of congenital hyperinsulinism is something related to the potassium ATP channel in beta cells, and mutation usually caused by ABCC8 gene mutation or KCNJ11. And that will lead to dysregulation of insulin secretion, and I will show that in illustration in the next couple of slides. Those babies with these gene mutations usually born large for gestation, so they'll be microsomic, and the glucose load or glucose infusion rate is greater than 8 milligram per kg per minute. Normally, the glucose requirement is 4 to 6 milligram per kg per minute, so if it proceeds and increases the glucose requirement, then that could be an indication of ongoing hyperinsulinism. So clinicians need to be aware of this. Other genes rather than the ABCC8 and KCNJ11 as listed on this slide. So let's go through this illustration, trying to understand a little bit on how the hyperinsulinism occurs. So if we have high glucose in the circulation, this is in normal physiology. High glucose means the glucose goes inside the cell, and that will increase the metabolism, resulting into a more ATP in proportion to the ADP. So that increase in the ATP that will enhance the potassium to go outside the cell, and through the potassium ATP channel, the ATP channel. Closure of this channel will result in depolarization of the membrane. Depolarization of the membrane will enhance the calcium influx, and when the calcium gets inside the beta cell, the insulin will be released outside. This is what happens normally when we have high glucose. If we have low glucose normally in normal physiology, so low glucose means low metabolism, and low metabolism, of course, will mean low ATP proportion to the ADP. Therefore, there will be no outflux of potassium and no calcium influx because the membrane will be hyper-repolarized, and therefore no calcium influx, no insulin secretion. What happens with the potassium ATP defect is these channels are defective. So regardless that you have low glucose, and regardless that there is no actual, so regardless low glucose, regardless the low metabolism and low ATP production, but these channels are always closed and making the depolarization of the membrane, that leads to calcium influxing, and the calcium influxing leads to insulin secretion outside, and that is causing hyperinsulinism. That is worrisome because already low glucose, already high insulin secretion in the circulation, and that insulin usually suppresses the ketogenesis process. Therefore, the patient will end up with having no fuel to the important cells in the body, like the brain cells. You have no glucose already and no ketones, which is because of the suppressed ketogenesis process. Therefore, the patient will be at risk of brain damage. Other genes can be affected in the case of hyperinsulinism. We just knew about the KCNJ11 and the ABCC8 working on these channels, but we have other genes working on the transporter cells or glucokinase gene, which is affecting the glucose and the formation of G6DP or the GADH gene mutation also. Other rare types of hyperinsulinism due to blood-1 mutation, and this one is associated usually hyperinsulinism with hyperammonemia. So the patient will have very high ammonia levels and will have a very interesting presenting features. Usually will have hypoglycemia postprandially or sometimes even with the fasting, and more sensitive to the diet that's containing high protein in that. They could have epilepsy, and interestingly, they are responsive to diazoxide. HNF4 alpha or HNF1 alpha is another cause of hyperinsulinism, and these gene mutations usually presenting in the family. So there will be family history of diabetes mellitus, and the same genes could be upregulatory or downregulatory. So, for example, at some point would be leading to hyperinsulinism, but at early adulthood will be responsible, and the same patient for developing MODY, the maturity onset diabetes of youth. And good news is diazoxide responsive as well. So it's important then to differentiate and to know there are two types of hyperinsulinism. It could be focal, only one area, usually less than 1 centimeter, is responsible for all the amount of insulin that's being secreted, leading to hypoglycemia, or could be diffuse, the whole pancreas is affected. And genetic testing can help us to predict which type are we dealing with. So if we have the homozygous biallelic mutation of ABCC8 or KCNJ11, then most likely we are dealing with diffuse hyperinsulinism. Whereas if it comes only paternally inherited mutation heterozygously, then perhaps we are dealing with focal congenital hyperinsulinism. Of course, we need a scan to confirm the diagnosis, and because the management will be different afterwards. Why is it important for us to have a prompt response? Why is that necessary? Because if hyperinsulinism exists and is existing, and there is a delayed diagnosis, so patients would be having perhaps developmental issues, speech delay, learning disability, behavioral issues, something related to autism as well, ADHD, or even as severe as physical disability. So basically, we would like to treat patients, diagnose them early, treat them properly to prevent any sort of brain damage. Management of congenital hyperinsulinism depends on 4 pillars. First of all, we need to treat the hypoglycemia that led to the diagnosis initially. So we would treat that immediately by giving like a fluid bolus, like 2 ml per kg with 10% dextrose, followed by maintenance infusion, and then we calculate the glucose infusion rate, and based on that, we see how the hypoglycemia is responding. We need to establish diagnosis, and establishment of diagnosis heavily depending on getting the critical sample at time of hypoglycemia. It doesn't matter that you collect the critical sample afterwards, because that will not test the mechanisms that are supposed to counteract the hypoglycemia. So it's important, very important, to collect a critical sample at time of hypoglycemia to get the biomarkers that you need to help you reaching a differential diagnosis and perhaps the congenital hyperinsulinism. Then the treatment based on the diagnosis, then we treat either medically or surgically. Of course, there will be a need for providing a feeding plan because those patients, as we said earlier, they would have recurrent hypoglycemias, and we'll see how it goes with the treatment, because sometimes medical treatment itself is not sufficient. You need to add some kind of slow-releasing carbs into their diet to prevent the hypoglycemia, especially at night. And then in the management, there'll be an important aspect about glucose monitoring for those patients to predict when hypoglycemia is happening or to prevent it, to see the pattern and to treat accordingly. And that could be either by measuring the blood glucose the classical way, the traditional way, or by continuous glucose monitoring as the technology advances these days. So through this kind of pathway, just algorithm to go through, if we have a suspected hypoglycemia, or there is a patient with hypoglycemia of blood glucose less than 50 milligram per deciliter or less than 3 millimole per liter, then we need to collect a critical sample. And based on the results that we're gonna get, if the results showing that is non-acidotic sample by carb is more than 18, it's important to know what's the free fatty acids and what is the beta-hydroxybutyrate. Beta-hydroxybutyrate can be measured on the bedside, as well as a sample can be sent to the lab for proper laboratory investigation. If we have non-ketotic and basically low ketones in here and low fatty acids, non-acidotic sample with hypoglycemia, so non-ketotic hypoglycemia, likely that we are dealing with hyperinsulinism. The C-peptide here can differentiate whether we're dealing with extremely rare condition, which can be exogenous injection of insulin, like in cases of Munchausen by proxy, or we're dealing with endogenous hyperinsulinism. So basically, we would have elevated C-peptide and insulin in such cases. Decreased hydroxybutyrate, but free fatty acids are high, then perhaps you are dealing with fatty acid oxidation defect. If the sample is acidotic with bicarb less than 15, look at the lactate. If the lactate is high, then perhaps you are dealing with gluconeogenesis defect, including glycogen storage disease type 1 or ethanol ingestion. If the ketones are high and the sample is acidotic, then perhaps you are dealing with ketotic hypoglycemia or glycogen, other types of glycogen storage disease, or could be cortisol deficiency. Of course, if the ACTH is high, then perhaps you are dealing with just primary adrenal disease. This is the critical sample. We need to collect a blood sample and urine sample. Blood sample including a lab sample for the glucose, insulin, C-peptide, ketone bodies, and that, as I said, it can be done on the side, bedside as well. Free fatty acids, amino acids, lactate, ammonia, usually helping differentiating metabolic causes, Ammonia, as in GLUT1 mutation, as we mentioned earlier. Bicarbonate will help you to say whether acidotic or non-acidotic, as well as the rest of the blood gas analysis. Acyl-carnitine to help with fatty acid oxidation disorder. Cortisol growth hormone to rule out other counteracting mechanisms that should prevent the hypoglycemia from happening. And of course, insulin growth factor binding protein 1, which can be useful in diagnosing congenital hyperinsulinism. The urine sample, as well, the first void sample after that hypoglycemic event, could be helpful to check for reducing substances, ketone bodies, amino acids, and organic acids, mainly for metabolic processes. So let's see here the biomarkers that usually aiding the diagnosis of congenital hyperinsulinism. So on this axis, the blood glucose, on the y-axis is plasma insulin. So if low glucose, supposed to be associated with high insulin, but that is not usual, that's not always. So as you see here, low glucose, but the insulin is not much high. So it's not necessary that with all cases of hyperinsulinism to have high insulin. It's enough to diagnose a case of congenital hyperinsulinism is to have any detected insulin inappropriately in terms of hypoglycemia. This is very important, because sometimes we see labs saying the insulin is with normal values within the normal range, but that is inappropriately normal. It shouldn't be within that normal range if the patient is hypoglycemic. Beta cells should be switched off. So any detectable insulin in terms of severe hypoglycemia, that is enough to diagnose hyperinsulinism. In this graph, we see here the plasma beta hydroxybutyrate and the plasma insulin. Here, the specificity and sensitivity is even higher than the glucose and insulin. If you see here on the left upper corner, the insulin is high, but there is no hydroxybutyrate. So undetected beta hydroxybutyrate in hyperinsulinemic sample, that is enough to diagnose congenital hyperinsulinism as well. And in this graph, we see the IGF, the insulin growth factor binding protein 1. As you see here, in types of potassium ATP channel mutations, congenital hyperinsulinism, most likely to see that you have low IGF-1 binding protein 1, whereas in cases of ketotic hypoglycemia, which is nothing to do with congenital hyperinsulinism, it's another cause of hypoglycemia, you could see how it's detected IGF binding protein 1. So that can be used another marker with very high sensitivity and specificity. Now, to diagnose congenital hyperinsulinism, just to cap, we need to have low glucose, inappropriately detected insulin or C-peptide, and inappropriately low free fatty acids, as well as beta hydroxybutyrate. How could we manage those patients? So initially, while we are still establishing diagnosis, we treat the hypoglycemia by giving dextrose infusion, as I mentioned, and then you put the patient on maintenance, and perhaps you need to titrate the amount of infused dextrose. Usually through the peripheral line, we give a dextrosity up to 12.5%. If it's more than 12.5%, we need a central line. If we reach a very high strength of dextrose, certainly we need a central line in a very decent vein. So perhaps we need a surgical access, a surgical line for those patients. To buy some time, we need to give sometimes glucagon. And unfortunately, glucagon is not that medication that we can give it very long time because of the stability of the drug. So we use it for short term until we establish a diagnosis, perhaps. And especially if we have a problem with the fluid overload in patients with requiring very high glycemic glucose infusion rate. So we don't want to continue just giving large amount of fluids, and the patients will have a fluid overload that could lead to heart failure, for example. So if we need to minimize the amount of infused fluid, at that time we could give IV glucagon, and usually the dose is 5 to 10 mics per kg per hour intravenously. So it will give us some time to reach a diagnosis, and need to be aware that it can be rarely causing necrolytic migratory erythema, as it appears on this picture. This Side effects usually disappears within 2 to 3 days after stopping the glucagon. The first line of management in patients with congenital hyperinsulinism is diazoxide, which is, you remember I showed you earlier the potassium ATP channel that is closed by mutation. So diazoxide is basically a channel opener, working on that channel, trying to make it work into stop the depolarization that is occurring and leading to calcium influx. We need to make sure that we have a baseline echocardiography to make sure this patient is not already having pulmonary hypertension or an issues with ejection fraction of their hearts, because diazoxide can lead to fluid retention. Therefore, by default, we usually give diuretics like chlorothiazide when we start the diazoxide. And the dose can be 5 to 15 milligram per kg per day in divided doses. Sometimes we give even smaller dose, like 3 milligram per kg per day. And some patients, they do respond to that low dose. We need to be aware of the side effects of diazoxide, as I mentioned earlier, the fluid retention and pulmonary hypertension, as well as the hypertrichosis, which is hirsutism as appears on this picture, sometimes hyperuricemia, and sometimes very rarely, less than 2%, I would say, the bone marrow suppression, mainly thrombocytopenia and or suppression of the appetite. Then you would hear us talking a lot about whether this patient is diazoxide responsive or non-diazoxide responsive. So that's because if the patient is diazoxide responsive, that will help us just carry on with the management. But if the patient is diazoxide unresponsive, then we need to move on to next steps of management. When would we say that? If the patient is able to generate ketones with blood glucose more than 2.8 or 3.3 millimole per liter, the idea is the patient is able to generate ketones. If the patient is able to generate ketones, means diazoxide has suppressed the insulin production. Because if there is high insulin, then the insulin is usually switching off the ketogenesis process. So if the patient is generating ketones, means the insulin has been suppressed. So that means that patient is responding to diazoxide. Or if the patient is able to fast for 18 hours with no hypoglycemia, or if the patient with the GLUT1 mutation, for example, is able to have a meal of food containing protein without having hypoglycemia. So that means that the patient is responding to treatment. If the patient is not responding, then we move to the second line therapy by giving octreotide, which is a somatostatin analog, and the dose usually is 5 to 40 mics per kg per day. That be given in divided 3 or 4 doses subcutaneously, or sometimes in certain patients we do give it through the same like insulin pump. We use that pump to deliver the octreotide subcutaneous infusion continuously 24/7. Preferably to be given when the baby is more than 2 months of age and it's proven it's non-focal congenital hyperinsulinism. But we do sometimes, when diazoxide, for example, is not available, we do start octreotide at a younger age. Tachyphylaxis is common with octreotide. By the time the dose of octreotide can be not much effective as it used to be. And side effects of octreotide can suppress the growth hormone, thyroid stimulating hormone, and adrenocorticotropic hormone as well. Gallbladder stones occurs about in 20–30% of the cases, transient transaminitis up to 40% of the cases, and rarely thrombosis and necrotizing enterocolitis. So as far as we are aware of these side effects, and with the complexity of babies, especially if they are born premature, then we need to be careful when we give the octreotide to them. Other new medications like long-acting somatostatin analogs, lanreotide, which is the somatolin autogel given by deep subcutaneous injections every 4 weeks, or the sandostatin LAR can be given intramuscularly every 4 weeks. So that helps with adherence to medication and better quality of life as well. Now we move to non-medical therapy is by taking the patient to surgery, and we do this if it's a focal type, so that we will identify the focus that is leading to production of high insulin by having the FDOPA scan, which is it's a type of PET CT scan. So if you identify the area that is producing too much insulin, patient can be taken to an expert surgeon who could be able to get that focus out, and usually the patient will be cured by the surgery. And the other indication for the surgical intervention that you failed all medication attempts and a very severe diffuse child that is not responsive to whatever medication you tried. But we need to be bearing in mind the post-operative complications, like perhaps some beta cells, which is still functioning with no concordance to the body and it's producing insulin, then patients would continue having hypoglycemias. On the long run, patients could be developing the vice versa of hyperinsulinism, where they have insulin insufficiency, having diabetes mellitus. And of course, by removing almost 98% of the pancreas, then the patient could be at risk of exocrine pancreatic insufficiency. So this is the pathway that we usually follow to assess the diazoxide response. If the patient is responsive, then we assess fasting tolerance, and if it's appropriate for age, then we discharge. So in neonates, for example, while the patient on diazoxide and maintained and everything is fine, stable, ready for discharge, we just make a 6 hours fast, making sure the baby is passing this test to be safe at home. We discharge baby on diazoxide, and then we'll arrange for follow-up. But if the patient is not responsive to diazoxide, it's important to run a rapid mutational analysis of ABCC8 and KCNJ11. Now, if it's paternally inherited, as we mentioned earlier, it could be focal, but if it's diffuse and diffuse disease, it will be usually homozygous or combined and heterozygous of both mutations. Then we will move to high calorie and volume feeds plus octreotide therapy, plus we might end up, if the patient is not responding medically, to near total pancreatectomy. But if it's paternally inherited, then we will move away with the 18 FDOPA PET CT scan. Unfortunately, it's not available in all countries, so there are certain centers in the world where they perform this scan. If it's focal disease, then we do surgical resection, whether laparoscopically, if possible, depends on the skills of the surgeon that we have access to. And then that potentially leading to curing of patients, but there's no guarantee. However, if the Doppler scan showing diffuse disease, then we go back to this square where patients would have high calorie and volume feeds plus octreotide, and if it's failed, then we move with near total pancreatectomy. If the patient is stable, as we mentioned earlier in the first arm, then usually just move on with follow-up. However, if routine genetic analysis afterwards with the gene panel that's resulted that there's a paternal ABCC8 or KCNJ11 gene mutation, then we need to move the FDOPA scan here, but to get the surgical removal of that focus that produces too much of insulin. General follow-up to monitor the growth and development, neurological assessment, and genetic counseling, of course. Now, we need to be aware of some common problems in patients with congenital hyperinsulinism. So feeding problem is very common in those patients. Food aversion or refusal, especially on those patients who require tube feeding for a very long time. So if the patient is requiring nasogastric tube or orogastric tube for a very long time, 75% of them, they will have a food aversion in the future. So we need to be careful for them to develop these skills. So we let them at time of weaning to taste the food, to let them to swallow some food, and preferably not to keep the orogastric or nasogastric tube for a very long time. You can switch it to a PEG, percutaneous gastrostomy kind of tubing feeds, and then making sure that the skills are gained through the oral route as well. This happens, the food aversion, as mentioned, one of the reasons is long-term usage of tube feeds, but sometimes also can be resulted due to changes in the gastric motility and anorexigenic effect of insulin, or could be due to adverse side effects, gastrointestinal side effects of medications being used, like octreotide or even diazoxide, or could be due to neurodevelopmental deficits. Now, education is very important, and we do educate our patients about congenital hyperinsulinism, and we provide them with written material. Congenital Hyperinsulinism International, they do amazing work, and I have translated this to them into Arabic, they do have congenital hyperinsulinism material in more than 17 languages. So you just need to visit their website, congenitalhigh.org, to find out the educational material that you can share with your patients. And it's very important to highlight to our patients and even our staff, make them aware about the symptoms and signs of hypoglycemia and what are the consequences of that happening. Now, after educating the parents and after discharging the patients, you need to monitor their glucose. So I'm proud to be one of the first people who studied the effect of continuous flash glucose monitoring in patients with congenital hyperinsulinism, where we carried on this kind of research in Liverpool back in 2016, 2017, and we got this published first time, the effect of CGM on, so we got the first report on accuracy and patient experience. What we found is, comparing to the capillary blood glucose, and here are the differences between the freestyle library to the capillary blood glucose. Ideally, we should not find a difference more than +2, -2 standard deviation. But what we found, we see red plots here. So there are sometimes differences, whether it's overread or underread readings through the freestyle library. But that at the time, we used the first generation of the freestyle library, resulted in having mean absolute relative difference of 17.9%. Of course, the lower MARD is the better way of measurement. So ideally, you should get the reading only on the green line, not to see anything on the orange, the yellow, orange, or red. But as you see here, there were some readings falling under. So we considered the MARD is high, and we could not recommend the continuous glucose monitoring at the time for accuracy, from accuracy point of view. However, the parents were very happy to use this type of glucose monitoring to know the trend of the glucose of their kids, what's going to happen to them. And so what is the prediction is going to be. Later on, researchers start working on this area, so continuous glucose monitoring and management of neonates with persistent hypoglycemia, congenital hyperinsulinemia by Mayat Win in 2021. They found the mean absolute relative difference is down to 11%. And there is another study was published in Diabetes Technology and Therapeutics. Again, this from 2020, a three-way accuracy comparison of Dexcom G5, the Freestyle Library Pro, and the Eversense, and their MARD, the Freestyle Library was similar to our study. Dexcom slightly better, but Eversense was even better. A very recent publication just this month by Madini with Pratik Shah group from London. They checked the accuracy and impact using Dexcom 5 and Dexcom 6, and they found the MARD is actually lower, down to 12.8%. So it could be there is some degree of accuracy with improvement of the technology here, and checking glucose, especially with real-time glucose. So those results is very encouraging to use technology these days and in monitoring glucose. At the end, I would like to thank you again for the invitation, and I will leave you this photo from the ASPED region where we met last year, trying to establish congenital hyperinsulinism registry in Middle East and North Africa. And I would be happy to take your questions. Thank you.
Dr. Hussein?
Yes.
Thank you very much. Thank you very much for your excellent presentation. Actually, my first patient with CHI, I was diagnosed 12 years ago. He was put on sandostatin for years, short-acting one, and then has been shifted to LAR. And he was doing excellent on LAR. Do you have an experience in using LAR and instead of sandostatin? The short-acting.
I haven't got my own experience of using LAR, but if your patient is stable on that, and you're saying that he's got excellent response to it, so perhaps you've reached the optimum of his management.
Yes, he was responding excellent, even for the short-acting ones, and then on LAR, he was doing very fine. But Then he developed pancreatitis.
Ah,
I
okay.
don't know if it is due to, as you know, somatostatin is one of managers for pancreatitis, but I wasn't sure why did he develop pancreatitis. Few months later, he was off sandostatin and he was doing excellent. Also, I did the genetics in Exeter 12 years ago. This one was my first patient, and diagnosis is made.
Yeah. Okay, so was it, do you think it was dose related, for example, with this LAR?
The dose was less, I think,
Okay.
and glucose was values was better than before, than on the regular ones.
Yeah.
It was very strange for me.
Okay, you said you use statin as well with it?
No, statin at first,
Somatostatin, yeah.
no, sandostatin at first, yes, and then the LAR one, and then off LAR.
Okay. A bit strange to me because, as you know, in adults, I do remember they used somatostatin in treatment of even acute pancreatitis. So use somatostatin in treatment rather than causing pancreatitis.
No, that's why I continued on sandostatin.
Yeah. And at the time of pancreatitis, did you investigate for other causes of pancreatitis? Could be a reason?
Yes. No, I didn't reach a reason for this pancreatitis.
Wow, okay.
No.
And I presume after that you restarted the LAR again, and
Yes.
it didn't happen again. So it wasn't like a recurrent pancreatitis.
Yes.
So in this case, perhaps the pancreatitis was not secondary to this medication.
Yes.
And that's most likely, yeah.
Yeah. But when he was off sandostatin, I was very astonished.
Okay.
Okay. Thank you very much.
Thank you.
Thanks a lot. We really enjoyed your presentation. We hope to meet you again soon. I know that you are doing an excellent job on either on the national level Norman or Arab level or ISBAD level or even SP. Thank you very much for your contribution. I really appreciate that. Thank you.
Thank you very much.
Bye-bye.